Hello everybody, I'm here Mrs. Brahmu. So today we are going to see about a very essential and important topic which is a must for all the nurses who are working at the intensive care unit, which is nothing but how do we sample or how do we take the blood sample for arterial blood gas analysis. So again I repeat, it's not like what is the interpretation we'll be seeing in the some other next class. So in this we are going to see about how do we do the sampling and what are the routes and how it should be taken and so on. So we will be skimming and scamming through these sessions. So you will be able to analyze at the end of the session like how to take a blood sample, what is ABG sampling, what are the steps being involved in ABG sampling, and you'll be able to plot out the possible principles of puncturing site and how do we select the site. You'll be also able to bring out or plot out the sites of sample puncturing, as well as what are the equipments and supplies which we needed for sampling, and what is the major procedure for ABG sampling, as well as you will be able to discuss about the techniques, or we call it as the steps, when you do the, if the patient is on any arterial catheters, how the sampling to be taken and what can be the possible sampling errors and how you can prevent those errors, as well as we will be also discussing about what are the possible complications of arterial blood gas analysis sampling puncture site. So what is ABG? So we all know it is arterial blood gas analysis sampling. So in this, the common route what we take is that it's not the vein but the artery. So as we are going to punch, as it is an invasive procedure, it is more essential that you use the glove and it should be done in a sterile technique. And as well we will need certain requirements, that is heparinized syringe before puncturing, as well as we will be doing certain analysis or test before doing the arterial puncture. And how do we transport that ABG blood sample and what is its time, and during the transportation what are the essential requirements needed, such as how do you bypass or how do you take the sample from the ICU to the sampling area or from the OT to the sampling area for analysis. So here in this picture you can see that the patient's hand is being well flexed and it is like hyperextended the wrist, and you can see the gloved finger is the hand, and the appendage syringe is the nurse who is going to do the procedure, and it is always placed under a roll of towel so that you can flex, or you can say otherwise hyperextension of the wrist, and you can palpate for the pulse, radial pulse, and then you can take the sample. So arterial blood gas analysis sampling is obtained via the arterial line, as I earlier told you. Usually it is an invasive procedure which is done by puncturing of either the radial artery, brachial artery or femoral artery. So before starting the specimen collection, what is the pre-procedure we do? So always we have to check the doctor's order, whether the order is given, or might be in otherwise, might be in case of emergency situations, if the patient is having very much of disturbances in the respiratory system, or if there is an evidence of a sudden cardiopulmonary arrest, or might be before you ship the patient to OT in order to know the level of oxygenation and the bicarb levels, or if the patient is unconscious. In those states the order will be specified, or in emergency situation it is a routine in certain hospitals they take the ABG analysis, but as a nurse it is very essential that you go with the doctor's order. So after you get the order, what you have to do is that we have to always identify the patient, because in your clinical side you will be having with the same name, might be you say Mr. X, another Mr. X also you can identify, and you will be explaining the procedure to the patient. If the patient is conscious or if the patient is unconscious, you can explain to the patient attenders and get the consent. And the possible articles, of course, we have to keep in hand so that it is not delaying the specimen to draw, or it is not delaying the wastage of time in and around the patient area. So these are the pre-checks you do before you start the specimen collection. So after that, what we have to do during the procedure is that always strict hand washing, and along with that you do a universal, that is you follow the precautions. So the universal precautions is that the other important thing is that before you take the sample is that temperature. So what is here the temperature very essential is that you have to know what is the patient's body temperature. So before we send the sample into the ABG machine, we will be setting the preset temperature of the patient. So accordingly you will be getting the value. Otherwise there will be bias, so sampling bias will be there depending upon the patient temperature. As we all know that the patient is either in the ICUs or OTs, so their temperature is always hypothermic, and if you go and just load the sample just without looking onto the patient's temperature, so you can get a small or slight variation where we cannot go in for the proper correction of the ABG sampling after you get the report from the ABG machine. And then ventilation. So here the ventilation is that they are coining about the breathing pattern, how the patient should be, what is the comfortable position you give, and just before the sampling, see that the patient is, whether he or she is having the O2 supply. So if the O2 supply is being given, so whether in what type of oxygenation the patient was receiving, whether it was non-invasive or invasive or without O2. So those details must be filled in along with the requisition form, or if you are charging against in a, might be in a setup where you do only go for digitalized, you have to give a keynote that what is the saturation as well as what is the ventilation the patient is on throughout the period of when the sample is being taken. And next is that you will be going on checking for the inspired oxygenation, that we call it as FiO2. So usually supplemental oxygenation will be maintained in the same setting, and at least for 20 minutes before the blood sampling. So you cannot alter the saturation, not the saturation, the oxygen concentration. For example, if the patient is having or receiving FiO2 of around 80 percentage, and then suddenly just before 5 minutes you are going to change the FiO2 or reduce the FiO2 to 60, and then immediately you take a sample, but actually what has happened, the patient was receiving only 80 percentage, but there will be a confusion whether the patient is now stabilizing with 80 percentage oxygenation or 20 percentage or 60 percentage oxygenation. That's the reason why always maintain the same FiO2 levels before at least 20 minutes before the sampling is being done. Then see that the ventilator settings, that is the PEEP and the CPAP. PEEP is the positive end expiratory pressure, and CPAP is the continuous positive airway pressure. That also should be maintained. You cannot change the PEEP and CPAP. For example, if PEEP is kept around 10 and suddenly you go and change for 5 and then take the sample, that may give a fault reading. As well as if the CPAP is being maintained around for the patient, the same value must be changed without changing at least 20 minutes before you take the sample. So see that always you follow the single arterial puncture, because in venous if you go for a second puncture, might be patient is having very minimal hematoma, but in case of arterial puncture there is high risk of decreased perfusion to that distal area receiving the blood supply. So hence always go with the principle that a single arterial puncture should be done. And when you're doing the puncturing, see that you're going to use a short bevel, sharp needle, and directly it is being attached to the syringe. Nowadays you get pre-filled heparinized syringe. In olden days what they used to do is that they may be using the insulin syringe, which is 1 cc syringe or might be 2 ml syringe, and then they take the heparin from the vial, and they the nurses, they themselves will dilute the heparinized syringe and then they take the puncture. But nowadays you have the pre-filled arterial syringe, so that can be taken for the procedure. And Also check in whether indwelling arterial needle cannulation or any flexible catheters is already placed. If there is any other cannula or catheter in the artery, might be in case of post CABG patients, you can see in the CTO-OT or in the CTO ICU, they will be having arterial cannula prefixed. So that can be used instead of constantly puncturing the artery. So here the thing is that continuously this particular arterial cannula will be placed under pressurized flush system, which is like they will be mixing along with the normal saline. Heparinized solution will be mixed, and then it will be connected to the catheter, and it will be also connected to the transducer. In certain patients, they also maintain the arterial BP. So the next important thing as a nurse, what we have to do is that we have to know the criteria for selection of site. So how we are going to select the area for puncture, whether there is a good blood flow, collateral blood flow is there, or you have to check for the size as well as the accessibility. So accessibility in the sense, for example, if the patient is having AV fistula on the right side, you cannot do the arterial puncture on that particular area, right radial or right brachial. For example, if the patient is having DVT, for those patients you cannot go in for a femoral puncture. So see that whether the patient is eligible to go in for that particular puncture site, as well as check in for the size of the artery. So the size of the artery in the sense there, here it is the meaning like you cannot go in for a smaller arteries like ulnar artery. Always go in for a larger artery, and don't go in for the branches. Instead, we will be going and focusing onto the main artery. And periarterial tissue, see that we are not going to puncture the periarterial tissues area, and because there can be this ecchymosis around the arterial tissue area as well. So that is the reason you will be going for these criteria before you select the site for puncture. So as we all know that always we will be going for the radial artery puncture, and the second most choice will be femoral artery. Rarely we also go in for brachial artery if the client is deferred to do femoral artery puncture or radial artery puncture. So what are the possible equipments and supplies we need to have in hand before we go and do the arterial puncture? As of course we need to have a heparinized syringe and needle, alcohol swabs for decontaminating the skin, and sterile gauze pieces in case after the post punctural site we will be applying that particular area. Dry gauze piece must be needed in order to prevent infection, cross infection. And then of course if we are going to transport the sample from one side to the other side, then we may need crushed ice packs for transportation to the laboratory. And of course we have to have the patient identification label and the records at side, so that you can check in before prior to take the sample, and sterile gloves as it is a sterile technique. So the procedure for arterial puncture is going like that. Like always, as I told you earlier, always check in for the arterial blood gas order, then feel the radial pulse, and you will be checking for both the wrist and see that which is the best site for doing the puncture. In case if you find that there is an extremity which is having inadequate blood flow, please do not use that particular site. And always in hand we have to do that. We have to immediately perform an Allen's test before you do the procedure. So what is Allen's test? So we'll be doing this test to find out how is the perfusion to the extremities. In case if we do a radial artery puncture, how the ulnar perfusion is taking place. As you can all see that the radial artery and the ulnar artery are in the arch fashion, and through that we are getting through all the digits are being supplied from the same arch. So in case if the radial artery is no hematoma is being formed, you can see that the ulnar artery will be receiving large amount of blood supply, and from the ulnar artery the digits will be receiving the blood supply. So what we do here is that we will be asking the patient to clench the hands tightly, and the examiner's hand will be using either the index and the thumb finger, and we will be palpating and feeling for the radial and the ulnar artery. Once the radial and ulnar artery is being felt, immediately what we do is that before giving the pressure, we ask the patient to open the wrist and close the wrist at least 5 to 10 times. This will increase the perfusion, or this will increase the blood flow to the lower extremities as well as upper extremity. So here this test will be done in the upper extremity. So after that what we do is that after 10 times of closing and opening of the wrist, immediately pressure is being placed on the radial and the ulnar artery, and initially what we do is that we remove slowly one of the artery, that is the ulnar artery, and check for the perfusion. So in this picture, in the third picture, you can see that the hands are somewhat little blanched with yellowish and pinkish color, and slowly the other radial artery is also slowly released, whereby you can see the pinkish perfusion on both the, like all the digits are receiving the pink blood flow. So this pink color change of the patient's hand denotes that there is good perfusion. For this cases, then modifying Shannon's test is we can go in for that. Puncture can be done, arterial puncture can be done, because patient will be receiving either through the ulnar artery, the digits will be receiving blood supply. So if the Allen's test is positive, the puncture can be done, and if it is negative, then what we do is that we have to change the wrist. After that what we do is that the arm should be kept in an abducted fashion with the palm facing upwards and the wrist is extended around 30 degrees, and we'll be stretching the patient's hand, wrist, and then we will be checking for the artery, that is the radial artery. And then once the puncture site is very kept aseptically closed, then after doing a sterile hand washing, then we will be going sterile hand rub also can be done. Then immediately a sterile glove is being donned, and we can maintain the sterile technique throughout the procedure. And see that you are going to do the skin decontamination by using sterile alcohol swabs. So after that, how we are going to take the sample is that always palpate for the radial artery, and then see that you remove the syringe cap, and with the bevel of the needle pointing upwards, we are going to puncture the skin around 5 to 10 mm distal to the finger directly over the artery. The puncture angle should be approximately 45 degrees towards the direction of blood flow. Then slowly we are advancing the needle and the syringe on the one hand, and continuously the other hand is being palpated for the radial artery. Immediately whenever you whenever you see the backflash of the arterial blood in the hub, that indicates that we no need to go any more further. Immediately we can draw the sample. Then after the syringe is being noted with the backflash phenomena, then the needle is kept still stationary in one hand, and gently we are removing the sample from by pulling out the plunger of the syringe until the syringe is filled. The desirable amount is usually 1 to 2 ml of blood, arterial blood for sample. So as soon after we have done, we have to close the needle in single hand technique, and then you can send the sample immediately to the laboratory. But before that, what we are going to do is that see that the needle and the syringe are being closed without any air getting entered inside the syringe, because if you place the air along with the sample, then there is a chance of sampling error. So see that the air must be expelled out, and see that we have to recap the syringe in a single hand technique. See that there is no needle stick injury when you are doing that procedure, and always label the patient's label and place it in the ice pack and immediately send it to the blood gas analyzer area. And after post punctural care must be given to the pressure site, that is the puncture site, with sterile gloves until there is no bleeding or oozing from the site. Around 5 to 10 minutes of compression is needed, as we have done the arterial puncture. In a venous puncture, it's not necessary that you are going to go for minutes, where the BT and CT, if the BT and bleeding time and clotting time is normal, and for those patients it is not necessary. Might be if the patient is already receiving heparin or any type of anticoagulants, see that this can also vary. You might need around 15 to 20 minutes per compression, and then you can do the tight bandage. And see that the patient's temperature must be placed, and immediately whenever you send the sample, so what is the area you have selected, how much ml we have taken, and what is the temperature of the patient must be reported to the laboratory. The other two sites will be brachial artery puncture and the femoral artery puncture. The patient's arm is fully extended and the wrist is rotated until maximum pulse is getting palpated with the index finger just above the skin creases in the antecubital fossa. So once you palpate for the brachial pulse, then we can slowly, the same thing, one hand will be palpating for the pulse and through the other hand we will be for poking into the skin, and directly you'll be waiting for the backflash phenomena. Once you get the backflash phenomena, we can take the sample. The same technique will be followed, but here it will be a 45-degree angle of insertion with the bevel up. In case of a femoral artery puncture, see that here also the strict aseptic technique to be followed, and palpate for the inguinal triangle area, and see that the patient is being kept in supine position with both the legs extended, and slowly palpate the vessels with two fingers. And after that, see that there should not be any contamination, because there is high risk for contaminating of the blood gas sample, because it is very close to the groin. Might be urine samples may get spilled, or might be if the patient is in diaper, then that also, and highly perspirated area. So see that you do a proper decontamination of the skin before you take the sample. And here what we do is that around 2 to 3 centimeters, while palpating the artery, the needle is punctured perpendicular to the skin, that is might be 90-degree angle, and then we will be between both the fingers, in between both the fingers the needle will be placed and punched. So the remaining, that is how do we take a sample from already pre-filled or pre-installed arterial line, we will be seeing in the further slides, and what are the possible complications, what are the challenges while drawing where sampling, all these will be seeing in the next video. Thank you.